Guam Regional Medical City, the first choice for all of your specialty care needs.
The Coconut Wireless is back. The Ray Gibson Show. Call now, 888-TALK. That's 888-8255.
So earlier we were talking about ecstasy, the drug ecstasy, and we had a rollicking conversation about it. And I said, I can see where ecstasy might be attractive for young people, with these little rave parties and things like that. And then it occurred to me, I'm 56, going to be 57 years old in May. What is the equivalent of ecstasy for somebody in our age group? Now, I could pose that as a serious, clinical question for the doctors and nurse that I have in front of me. But my cop friend said it's Benadryl. Benadryl would be the equivalent of ecstasy, and I'm getting a look from the doctor over here saying, "Well, I don't know about that." Let me go around the room and say good morning to everybody. And I love a returning guest. Dr. Joseph Wiedermann is here. It's great to have you back.
Thank you very much. I'm happy to be here.
Well, not as happy as we would be if we were having the conversation on the beach. We were just exchanging notes on sun tanning, and so you've got a couple of spots that you like to go to get your grill marks, right?
Oh, absolutely. I love Retidian, and I love that beach north of Tanguisan.
Yeah?
Yeah, just lovely. Spend most of my weekends out there.
Yeah. Well, have you tried climbing the cliff yet? You know that you can do that. You know that there's a trail up on the cliff from about the area that you're describing.
I did not know that.
Yes, it's a fact. It's not too rugged, not too dangerous. It take you about an hour to get a half hour to get up and about a half hour to get down. And just it's a nice diversion if you feel like getting up from the sand.
Well, usually I've gone hiking down in the south because then when I finished my hikes, last weekend we went to Tanago Falls. On the way back from the hike, it's always possible to stop at McCrout's for a beer, which is the attraction.
See, if the doctor says stop at McCrout's for a beer, that's almost a prescription in my mind.
One drink a day reduces your cardiovascular risk. You just have to keep it to one.
Well, I've seen some of the tankards that they give you at McCrout's.
That's true.
So that might count as just
that would count
one.
as more than one. Yes.
Great to have you here in the studio, and we've also got Dr. David Woska, who's a cardiologist with Guam Regional Medical City. I don't think you and I have had the opportunity to meet and say hello to each other.
No, we have not, but I'm thrilled to be here.
Well, welcome to Guam. How long have you been here?
Thank you so much. I've been here 1 year and 3 months.
Mm-hmm. So, I mean, do we need more cardiologists? Because I got the interventional cardiologist over here, and then I've got. All right, so would that be interventional cardiologist and then cardiologist light? How's that work?
Well, there's sort of 4 different types of cardiologists. One is interventional.
Mm-hmm.
Okay. The cardiologist that does stenting and peripheral work, and then you have like the non-invasive cardiologist, which reads echoes, does stress tests, sees consults, that type of thing.
Okay.
You have the invasive / non-interventional, which is what
That's
I am.
the surgeon, right? So you're the rock star.
Oh no, I'm not
Nope.
the surgeon.
Oh.
No, completely different training program. But I'm the invasive / non-interventional cardiologist, where I do procedures, but I don't do intervention like stenting.
Uh-huh.
Okay. And then you have the electrophysiologist, who is really the electrician of the heart. Okay, so there's multiple types of cardiologists.
Okay, and we have versions of all of these disciplines over at GRMC? Or working towards that, because it sounds like, I mean, this is. I remember when it was just doctors, and you get a heart attack, and they'll zap you with something, and you're going to make it or you're not going to make it. But it now sounds like there's so many different disciplines involved here, and so many different ways to that you might be able to address issues with the heart.
Right. Well, I mean, there is a significant amount of overlap, between the types of cardiologists.
As one would imagine,
It's
yeah.
not like we're limited to just doing, 1 or 2 particular things.
Right. Okay.
So
well,
there's a lot of overlap.
All right. So for the listeners now, we'll go back and revive, if you will, reprise our understanding of an interventional cardiologist, and what is the typical patient that would be presenting to you?
Well, mostly I would be seeing people who actually had angina, that is chest pain with effort that is due to coronary disease. We want to fix the coronary disease, or people who came in with heart attacks either acutely or a couple days ago, where we want to take pictures of the arteries, find the blockage that caused the heart attack, and fix it, usually with a stent, to prevent any expansion of the heart attack or recurrence, or really normalize blood flow to the artery and stabilize the patient. So that's mostly what we do. I also take care of patients with blockages in their peripheral arteries. So if you have blockages in the arteries in your legs and you have pain when you walk, or blockages in the arteries in the kidneys, we do sort of vascular intervention everywhere. But the majority of the work is fixing people with unstable anginal syndromes, with pain when they walk or shortness of breath when they walk, or acute heart attacks.
Right. You shouldn't be able to feel your organs in your chest, and when you do, make sure that you call somebody, especially if you think it might be coming from the region where the heart is. Now, I remember from our last conversation that you've got this device. It's like a Dremel on a cord that you stick inside the vein, and you can clean out the inside, a roto-root of the vein from the inside at about 70,000 RPM. Have you gotten a chance to use that recently?
Oh, yes. I've used it quite a bit. It's actually, we treat arteries because the veins are just to return the blood. The arteries are the ones that actually give the oxygenated blood to the heart.
I'm just a talk show guy. It's all the same to me.
So the drill, it's actually a diamond-studded drill bit that is of the size of the artery or a little bit smaller, and we spin it at about 140,000 RPM. And what that does, we use that in arteries that are very calcified, which happens in older patients, and it's a way of allowing us then to put stents in, because some of these calcified arteries are so rigid that the stents won't pass. So in about, a significant number of patients where we can't treat them any other way, we use the drill first, and then we put in a stent.
Right. So you make the hole a little bit wider, and then you've got something that'll prop it open and keep things going there.
Yes.
I lost a friend recently to a woman to a heart attack. She's 59 years old, and anybody listening knows exactly who I'm talking about. And, well, I've got a couple of cardiologists here in the studio. Well, are there differences, significant differences in the onset, the symptoms of a heart attack for men and women? I mean, if I'm a guy, what should I be looking for? If I'm a woman of a certain age, what should I be looking for?
All right, so the majority of people, both men and women, will experience either severe chest pressure accompanied by nausea and sweating, or a lot of shortness of breath. Again, that's the majority both for men and women. But women do have a higher proportion of atypical symptoms. So that means they can just present sometimes with overall malaise that doesn't seem to go away, or a lot of nausea and a really bad abdominal pain, like a bad stomach ache. And they'll often dismiss it as, oh, this is just my stomach. And that's the thing, that women do have more atypical symptoms. So if they're just feeling poorly, or if they really have a bad tummy ache that doesn't seem to go away, it's time to seek medical attention, because it's much better to come to the hospital and get an EKG and be safe than find out that what you've been feeling for the last 3 hours is actually a heart attack.
Right. I'm sure you concur, Dr. Wasko?
Oh, I do. I think in the past, and maybe even now, physicians are still not completely aware that women can present differently. In the past, I think doctors have been thought to perhaps dismiss a lot of women with these symptoms. Oh, you have anxiety. Oh, you have this. Oh, it's something else.
Menopause, premenopausal.
When in fact it really is cardiac disease. But that's becoming more and more obvious to the medical community, and I think we're definitely looking into these atypical symptoms much more now than in the past.
Interesting. As we move a little bit further, and the one person I haven't introduced yet is Carla Haddock. And now, just when are you going to become a doctor? You're like 2 more tests away from becoming a doctor, right?
Well, I actually graduated in May, passed May, and got my licensure as a family nurse practitioner and acute care nurse practitioner.
Right.
So I am practicing now as a nurse practitioner.
Now, and are you only at Guam Regional Medical City now?
I wouldn't want to say I'm only there, so I still have my gig with the U.S. Navy doing recruiting.
Yeah.
And then I part-time at GRMC and looking to help a couple of other clinics on island.
And then you've got 20 kids.
Yes, and I have 20 kids.
And a husband.
And a husband.
Yeah, and how do you manage? Let me just, for that one there, I mean, how do you take that? You've got so much going on. You're just one of those people that just has to have something happening all the time?
Well,
I've never, ever seen you relax.
Being a nurse for 10 years at GMH, and you see how much the island needs people and needs providers and needs the access to care, it just makes sense. And my husband, thank God, is supportive of me and is like, do what you need to do to make yourself happy and help the people at this island.
So his support so far is on Facebook Live, where he says, wow, what a pretty nurse.
Wow.
There you go. That's going to be 21 kids. So So then now we go into some of the things. I was talking with the doctors about different things that the patients may come in and present and say, okay, I've got this pain, or I've got these symptoms, irritable bowel, or I can't make myself happy. I don't know what's going on, and it might be a heart attack. So what do you are in a heart failure management program. So would you see those patients, or are you more of a kind of a intervention?
Yeah, so what we're kind of piloting at GRMC is Guam has a high rate of heart failure, and that could come from if you have a heart attack or you just have this heart disease that you are now diagnosed with heart failure. And so what I'm trying to do is really find this cohort of patients and get them that early access care to come in and be seen and do a lot of patient education, a lot of medication management, and lifestyle modifications.
That sounds like the word is exercise and diet. Those are the two words when it comes to lifestyle modifications.
Well, not only that, smoking cessation, just understanding really your diet, stress reduction, all of those things.
Let's, for me, and remind me, because it's been a long time since I've asked the question, and either or both doctors can answer, why is smoking connected to heart disease?
Smoking is a disaster. I don't know if you as a child had science classes where they dropped little bits of nicotine on a fish's tail, because we used to do that in primary school. It causes spasm.
What?
Yeah, that was one of the things we did in science class. You had a little microscope and you
Where'd
looked
you
at the
go to
fish's
school?
tail in New York City. Yeah. Anyway, what it does is a couple of things. First of all, it causes spasm in all your blood vessels, so it contracts it. It also damages the inner lining of the artery, so that even if your cholesterol is normal, your cholesterol is much more likely to deposit on the arterial wall when it's damaged, because the nicotine and the toxins in cigarette smoke will damage it. And one of the worst things about it is we can't do anything about it. We can treat cholesterol, we can treat diabetes. We can't do anything about smoking except tell you to stop. Yeah. And it's absolutely the worst possible thing you can do to your heart.
Right.
Doc,
Well,
that sounded a little lectury. What about you?
well, I mean, I would agree with that. The only thing that I would add also is that they've done analyses on what risk factors are really most important in terms of preventing further cardiac events. And they compared all of the things like control of hypertension, control of cholesterol, smoking, and stop smoking is the number one thing that patients can do to markedly reduce their risk of a future cardiac event. It wasn't, control of cholesterol, control of high blood pressure. Now, all that's very important, obviously.
But if you're a smoker, quit.
But absolutely, that's the number one thing you can do to reduce your risk of a future cardiac event.
Okay, I quit smoking 10 years ago. I was a 30-year smoker for a long, long time. How long do you suppose the recovery for me is going to take, or has it already?
The answer to that is actually quite available. After 10 years, your cardiac risk goes down to baseline. So you are now back at normal cardiac risk. It takes a little longer for the risk of lung disease to go down. So it may take as long as 20 years to go back to baseline. But you are already essentially free of cardiac risk from your past smoking.
Okay, so it's not. It will get better from there, from the second that you stop smoking.
It gets dramatically better in the first year and continues to improve in terms of the risk of events for about 10 years. And then you're really just like anybody else after 10 years of not smoking from a cardiac point of view. Like I said, the lungs take a little longer.
So are you two going to help Carla set up this cohort list of people that we can populate this heart attack management program?
Yeah.
We work together, yes.
Yeah.
we
So
do.
all three
We
of
do.
us are working great. Also, we identify patients who present to the ER or inpatient, and I kind of tag them on my list. I might visit them in the ER if I'm in the hospital, or visit them inpatient, so we can get a follow-up visit within 7 days of discharge.
How many people are we talking about?
Ooh.
Because 165,000, and we start.
So I mean, we have some preliminary data. We had about maybe 500 encounters last year for heart failure at GRMC. So we're talking about a significant number of patients on island. But I mean, you can't always capture everybody who's out there.
I was going to say, I mean, between the GRMC Guam Memorial Hospital and 500 or so, and that doesn't include any numbers that we might be getting at Navy Hospital, is that number high or low or about right for Guam?
I think we're way under capturing what's out there. I mean, I think there's Part of it is patients are not really coming to the hospital sometimes or not seeking medical attention. And part of it is we don't really have a coordinated database yet, which allows us to capture GMH, GRMC, and Navy. So I think the 500 is a lot less that's out there. That's why she's trying to recruit more people so we can take care of them.
Are there any numbers from CDC?
The last
World
CDC report was in 2012, I believe, because we do put out a fact book, World Health data. Part of the problem is our sole epidemiologist at Public Health retired, and we quite haven't filled the spot. So I think also our data hasn't been captured greatly about our diseases on this island.
Right.
And there's been no report that's been needed to be generated yet.
So if I've been to Guam Regional Medical City and I thought maybe I was having a heart attack, or if I've got other other symptoms that might put me in a category where I am the potential for me to become a victim of a heart attack is real, how do I get in this program?
So all it needs is a referral over, just so that we know your name, your number, and then we give you a call and schedule you in.
Okay, and how much will it cost for me to be a part of your heart failure management program? Is there?
Well, insurance usually takes care of it. So, it is a provider visit. So if you have insurance, it's all based upon your insurance.
Okay, and then you were talking about some things that you might be able to do to get in front of heart failure. We talked about diet, exercise, lifestyle changes, quit smoking. What'd you say? One big beer a day, one just monster beer.
One alcoholic drink a day does seem to reduce your cardiac risk. You can pretty much break even at 2, and if you're hitting 3, you're doing more damage to your liver than you're helping your heart.
You're worrying about your heart. Okay. Well, there's always a little bit of give and take, right?
Yeah.
I got you. Are there connections to alcohol and heart?
Oh, yes. I mean, actually, high doses of alcohol, people who are really heavy drinkers, can damage the heart muscle and cause what's called alcoholic cardiomyopathy, where the heart muscle itself does not pump well. So lots of alcohol is a cardiac toxin, a direct cardiac toxin.
Are we talking about the same thing with like cigarettes? So if the minute you quit drinking, you reduce the risk of that?
Well, the problem is how much damage has already been done by your drinking. So certainly if you stop drinking, the heart muscle weakness can improve, but it really depends how long it's been weak and how permanent the damage is. So with that, it's a question of as soon as you notice a drop in heart muscle, overall heart muscle contractility, that's when you stop drinking, because if you wait too long, then it can be irreversible.
Contractility. It sounds like you and Mike are going to the same school of buzzwords in the program. Mike gives me a new one for weather every day. How do we check on that? I mean, is there a test that you got?
Oh yeah, there's a very easy test. We do an echocardiogram, an ultrasound of the heart, which looks at how the heart muscle contracts in multiple projections, and we look at a number called ejection fraction, which basically just means what percent of the heart volume is ejected in one beat.
Okay.
And a normal ejection fraction is, let's say, above 50%. Once you start getting into numbers like 35%, you get into heart failure, and that can be measured very easily with a non-invasive test, which my colleague, Dr. Woska, looks at every day. So that's a very easy, available test, not expensive.
And based on those tests, I mean, is with the potential for recovery good?
Well, it certainly can be. If you stop drinking excessive alcohol. Now, the question is, how much alcohol really are we talking per day that might cause you to have cardiomyopathy? In general, it's thought
if they're waiting for you at the bar and the beer's already there just because they saw you park the car, I mean, that's a pretty good indication that maybe there's some issues there.
In general.
Sometimes I apologize for being late.
Well, in general, it's thought that you really have to drink, 5 to 7 alcoholic drinks per day for about 5 to 7 years, in general.
Right.
Now, obviously, everybody's different. There's variation. But that's sort of the amount of alcohol that may cause you to develop weakened heart muscle, which is the alcoholic cardiomyopathy.
Yeah.
Just remember, women are smaller, and less alcohol does more damage.
Yeah. Right. Same things moving around from there. Now, what are some of the other things that you're going to be doing with these patients once you've got them into this management program?
Yeah, so we take a good look at all of their medication, make sure they're on the right thing, because there's a lot of evidence that say when you have heart failures, to help reduce the disease progression, you need to be on all these things.
Nobody takes medicine here.
I know.
You know, you're right. I'm not too far off.
Yeah.
Isn't that it? I mean, how many times do you prescribe medicine to people, and they might be real good on their regime for the first couple of days, first couple of weeks. You check on them, and all of a sudden, instead of reversing, their situation gets worse, and you find out it's because they're taking holidays on their medication. That's a big problem.
Absolutely. It's one of the biggest problems here on Guam is compliance with medicines.
But then also understanding, bringing them into the clinic and say, okay, why did you stop? What are the barriers for you? Is it money? Is it cost? Is it you just don't like it? Are there side effects that you're feeling?
Right.
So it's kind of trying to empower the patients and really understand what could be some barriers for them.
Are there issues? In my head, I'm thinking about people in a certain age group, and the heart attack years and things like that. Or as people age, there are other complications that pop up. Is that a problem for you doctors as cardiologists, being able to prescribe medication that don't have so many contraindications to other medicines that they're taking?
Well, there are multiple comorbidities, as we get older. I mean, the development of diabetes, hypertension, et cetera. So we're not just treating one disease process. And all of these, interact with each other, and that's why they call it comorbid conditions.
Yeah.
And so each one of those conditions, of course, has its own set of medications and this and that. So coming to a place like GRMC, in the cardiology clinic, we can look at all of these different medications and perhaps determine if there's any real drug-to-drug interaction occurring, between the medications. In addition, a lot of these patients come in and they've seen different physicians who start them on different medications.
Right.
So what we sometimes think they're on is not really what they're on. And some of these medications can certainly interact with each other.
Would something like your heart failure management program try to coordinate the cooperation among the different doctors and the different disciplines to make sure that we're kind of fine tuning the therapy correctly, or is that something that would be done in the individual doctors' offices?
Well, what we really need to do is we need to have more integration with their primary care providers. But unfortunately, on this island, we know that half of the people don't have primary care providers. And so they treat
so you
specialists.
meet them in the emergency room.
Or we meet them in the emergency room, or we meet them in the hospital, or when we ask them, who's your primary care, they'll say, oh, my cardiologist or my nephrologist, or, And so if we had that, if the patient comes in and tells me I have a good primary care, we send a copy of the note and what we're doing over to them. So there's great care coordination, but that always doesn't work. So
can I throw out a couple of holistic questions for you? And when I say holistic, I mean different kinds of therapies that we can use, as opposed to always taking some kind of a drug in the bottle. I mean, maybe this is part of the lifestyle change that you're talking about. But recommendations for people to begin to explore, say, a vegan diet or something like that, or what do they call them? Fruitopians, people that's all we're going to eat is some kind of a fruit. Do you guys look at those and think of the therapeutic value for heart patients?
Well, again, depending on the nature of the diet, certainly any diet that's a low-fat diet is useful from the heart's point of view. So from our point of view, avoiding things like too much red meat, fried food, eggs, butter, cheese will keep your cholesterol lower. And avoiding too much starch, which in Guam really means rice, is a way of avoiding getting diabetes. Right. Well, that's a problem. Fruit is fine. The problem with some of the vegan diets is that a lot of the vegan diets use very high fat sources to substitute. I mean, you can get fat from some of those beans and grains as well.
Sure.
So you have to be careful about how you do it. But, there's nothing wrong with exploring alternative diets. You should just discuss it with your physician to see if we can work out something that makes sense for you.
Right. That's interesting. And just I need some kind of personal verification on this. I take 2 pills in the morning. One of them is a multivitamin, and the other one is fish oil. And so I've got a couple of doctors here. Is it doing me any good? Would it make any kind of difference if I stopped?
Probably not. All right, so fish oils have been shown to be beneficial in people with high triglycerides or people who've had previous heart attacks, and even there it's controversial. For most people, especially in Guam where you eat a lot of fish, it's probably not that helpful. And vitamins, I will say flat out here, are a scam. Most people who eat a normal diet, like your parents told you, with 3 colors on your plate, most people don't need vitamins. Vegetarians may well need vitamins. Vegans certainly need vitamins. And there may be other classes of elderly patients who need them. For the most part, vitamins are a marketing gimmick.
Okay, so well, I don't have a normal diet. I've been in radio all of my life, and my current diet consists of pork and beans, beefaroni, and chili with no beans.
All right, get your blood tested for cholesterol.
It's impossible. And they all from the same manufacturer. Isn't that kind of crazy? I don't want to take a break yet. Hold on a second. My producer's sending me into a break because the thoughts are in my head now, and I wanted to go back and forth between that and the Facebook Live to see if there's any questions over there. There is a question from Nate Horn, and we'll return back to the cardiology and the heart failure program, but I do want to address a couple of things that are online right now. Nate Horn asking doctor's opinion on medicinal marijuana and edible versus smoking. Guys?
I don't know much about the medicinal marijuana, quite honestly. Smoking, I certainly would not recommend that.
Ingesting it smoke-wise.
It's been proven, it has been proven that marijuana will increase your risk of an MI, especially within the first hour.
What's the MI?
Heart attack.
Ah.
Heart attack, yeah, within the first hour. Okay, so there is an increased risk of heart attack.
I never heard of that.
It's a small increase.
Hour.
Okay.
Yeah.
Okay. Right. But because has anybody ever died from that?
Well, it depends what else is going on in the patient.
Because you get a lot of these guys that are on the pro medicinal marijuana side, and they say marijuana is good, alcohol is bad, and so this ought to be.
It depends medicinal for what. There is some data that shows that marijuana can be very useful for certain seizure disorders. It's also really good for controlling nausea in cancer patients. And it's actually interesting. There's some data on comparing it with risk of lung cancer compared to cigarettes.
Right.
And the equivalence is basically one joint is equivalent to 4 cigarettes in terms of cancer risk. So if you actually smoke an entire joint by yourself, you're smoking about 4 cigarettes.
Okay.
In terms of other things like...
There's people listening saying, I'll take that. I like those odds.
Right. One of the real problems is because of what the federal government has forbidden over the last 30 years, there's very little data. We haven't actually been allowed to study this.
Right.
So a lot of these things are very speculative. We don't know because the NIH was not allowed to study it.
Well, there's conversations about pain management, and as you say, I don't know if I smoke a marijuana joint, whether that will be any more or less useful in pain management than popping 2 Tylenols.
I would go on a limb here and say, if anything, it's no more dangerous than popping 2 Tylenols. Tylenols can be bad for your liver in the long run.
Yep.
But again, there has not been a lot of study. I would say, one thing which should always be emphasized is don't drive, because you may think you're driving safely, but in fact there is good data showing that reflexes are impaired. It may not be as bad as alcohol, but it does increase your chance of having a motor vehicle accident.
Well, there's that one ought to go down as something that's kind of obvious. But are there any therapeutic values that either one of you can cite for specifically heart conditions? I mean, has there ever been a case where you've thought about somebody's particular presentation, what kind of symptoms they're coming in with, and said, you know what, we might be able to relieve you of those symptoms if you eat a brownie or
not that I know of.
I've never prescribed it.
Nothing.
There's no data on it. I mean, again, you could sort of theorize and say, well, they really get arrhythmias because they're having panic attacks. Maybe the marijuana will help their anxiety, and maybe that's safer than the benzodiazepine. But this is complete speculation.
Yeah.
No one knows.
And until we get around to getting the research done and then the analysis of the research over a course of years, it's not going to happen. I want to take just a real there's my friend Dave. MI, myocardial infarction. That equals a heart attack. Thanks very much. I try to avoid buzzwords because I don't know what the heck they are. 9:35. And we're going to take a real quick break here. On the way back, I am wearing something on me now that I think might have some kind of value to this program, and so I'm going to bring that up with him in a second. In the meantime, that's iConnect time. Swing by iConnect at 9:35 in the morning and ask them about great plans and features and programs that they've got for you in 2019. Push to talk? Yes. Mobile? Yes. Internet? Check. Find out more by calling 888-8888.
At Guam Regional Medical City, it is our mission to become the island's premier choice for specialty care, like cardiology, pulmonology, neurosciences, orthopedics, oncology services, and more. We aim to protect our island from heart attacks, strokes, cancer, and diabetic complications. But should you suffer from such diseases, we're ready with world-class options, both inpatient and outpatient. For more information, visit us at grmc.gu.
Hey, go eat it at Wendy's. In fact, I'm going to treat the doctors to some Wendy's a little bit later on. Peppercorn mushroom melt, barbecue cheeseburger with sweet and smoky barbecue sauce, and the Sauce'em bacon cheeseburger. That's the one that's got bacon on it. And you can say what you want to about alcohol and cigarettes, but lay off on the bacon. Bacon is always going to be healthy, right? Just let me live in my own world here. It's the new Made to Crave menu at Wendy's. Get it today.
It's important to have claims process that works for you. At Guam Insurance Services, we make things simple and convenient. Same door you walk in to purchase your insurance is the same door you open to file your claim. We can't pretend that the car insurance claims process is fun, but we can promise a hassle-free and speedy recovery without any runarounds. For your home, auto, and business insurance, visit us at the Camacho Landmark Center on Marine Corps Drive in Tamuning. Don't forget to like us on Facebook or give us a call at 475-1162 or text 929-SAVE. That's 929-7283.
My buddy Jose Martinez online, Vincent Bernard and Doreen Menabusen and Aisha McKinnon here, and I'm kind of curious about something, and to the degree that there seems to be a lot more attention that is being paid now on digital kind of surveillance devices. I mean, there was once upon a time, if you wanted to know what was going on in your body, you had to be hooked up to something, and in 2019, I can go to Beyond the Box and get one of these Apple Watches, and this thing here will tell me what my heart rate is doing, and I believe that I want to say that there is something like an EKG device that is built into this, and there are a lot more opportunities for doctors to be able to say, wear this watch and have it upload some information to me so I can see what's going on with your innards. Are you beginning to look at the value of some of this wearable technology?
Well, yes. I mean, I think that
Checking to see if you've got one.
Things like an Apple Watch that actually has one of the sort of apps that allows you to measure EKG can be very useful in detecting arrhythmic events in certain patients. We're just beginning to study that, but the FDA is actually approving it for that use. We've been doing this for years. Before there were things like Apple Watch, there are very tiny implantable devices that we put under the skin that are long-term monitors for arrhythmias. There are electronic devices that are implanted by which from a distance we could administer insulin and adjust doses. So this kind of electronic implantable stuff has been going on in medicine for at least 10 years now. An Apple Watch is just a simpler version of the same thing, and I'm very much in favor of it, though one needs to caution people it's not as accurate as an EKG, and you'll also, depending on your personality, make yourself crazy if you keep checking your own EKG every 10 minutes on your watch.
And we know people that do exactly that. I'm trying to remember. I might actually know people that have an implant that will allow them to be able to see what's going on inside their bodies on a regular basis, and it's usually heart patients that get those, right?
Yes.
Yes.
Yeah. Is that a procedure that we're talking about at GRMC? Is that something that we have, or it can be made available?
That's currently not available here. I think what Joe's talking about are the loop recorders that can be actually placed subcutaneously.
Right.
They don't have to have like major surgery. It's a very minor procedure. Goes underneath the skin, and it can stay with the patient for a year, year and a half, 2 years. There are patients that still have loop recorders in like years later, even though they perhaps haven't had any bad events. We just leave them in.
Why not?
If they're not having any complications from it.
Now, does that help in if something does happen? You're able to, if you're using the term loop recorder the same way that I'm familiar with it, is it something that's just like the airplane's black box? We keep 5 minutes rolling all the time. Something happens, then we've got a record of it and can see exactly what was going on in the patient's body that led up to this dramatic moment.
Exactly. This is a device that is very helpful in patients that have intermittent symptoms. Okay, so for example, if you have bad dizziness, lightheadedness, shortness of breath, intermittently,
Right.
where other tests have failed to really diagnose what's going on.
Well, it's nice to have something.
It's nice to
something in
have
the
it
body.
continuously monitoring you in order to catch that event.
I'm glad this guy is on the phone. You might want to share up the headphones, although I'm sure it'll be loud enough so that you'll be able to hear. Bob Kelly is on the line, and Bob has had just some interesting heart surgeries in his life. In fact, fairly recently. And last time he and I talked, he said he talked to his doctor, and the doctor said he's got the heart of a 17-year-old now, based on all the.
It was a 19.
19-year-old, and one of these days we'll find that 19-year-old and give him his heart back. It's at 9:41 in the morning. Bob, welcome to the program.
Hi. Well, what I was going to just say, I'm an AFib survivor. At age 65, on my birthday, I was diagnosed by AFib. It really ticked me off because they made me go to the hospital on my birthday, spend several days in it, loaded me up with all sorts of medicines, and I was somewhat into depression after that because I didn't want to live that kind of a life. And so doing research, and I understood then the dangers of having AFib, I found in Houston a doctor who does a maze, which is basically burning or catheterizing the nerves that is causing the AFib. And I was able to get that particular surgery, and my ejection rate went from below 50 to almost 70%.
So it was a success, it sounds like.
Yeah, this is a very accepted procedure for people with AFib, especially if their rates are so fast that they're causing heart muscle dysfunction.
Close to 70%.
Yeah, it sounds like obviously a dramatic improvement. Let me just ask the doctor real quick. Tell me a little bit more about the procedure. He's talking about catheterization.
So this is an electrophysiology procedure,
Okay.
and it basically, AFib is a chaotic rhythm where the electricity is conducted randomly inside the upper chambers of the heart. And this procedure is a kind of ablation where you use radio frequency to burn parts of the left atrium to prevent this chaotic rhythm from being transmitted. And after an ablation, there's generally about a 80% success with the first ablation. Some people need 2 ablations, but it pretty much gets rid of the atrial fibrillation. And if you don't tolerate the medications, or if you're having afibrillation that causes heart rates so high that it's causing heart muscle dysfunction, which it sounded like it was going on in this gentleman, then an ablation is a perfectly reasonable procedure. We do not have an electrophysiologist in Guam, partially because it's not really covered by insurance in Guam. But this is a common procedure, certainly performed anywhere on the mainland of the U.S., and maybe eventually we'll manage to work out the insurance issues here.
So we're talking about a chaotic heart rate here. Is
Rhythm.
that rhythm? Now, is that something that in the old days would have been handled by a pacemaker?
No. I mean, again, this is really more a very rapid rhythm that in the atria can go at 300-400 beats a minute.
Hey.
So that is not transmitted to the pumping chambers of the heart, but it's not something that requires a pacemaker for itself. Usually pacemakers are given to people with very slow heart rates that are fainting.
All right, and we need those to be kicked up every once in a while. So the pacemaker watches it. When it slows down too much, then it hits it with a couple of zaps and gets it back on pace.
Or just supports it. If it's always slow, the pacemaker is always working. It kind of depends whether you need it for backup or all the time.
All right. Now, Bob, what was it? Bob, what were your symptoms?
One of the things that bothered me, it was the medication I needed with AFib, and I was on this medication for about 3 months before I got the surgery to prevent a stroke, and that's the blood thinners. And the blood thinners, when you read all of the cautions on them, they sound like the blood thinners are almost as dangerous as what you're trying to prevent. But there's also a little part in the upper part of your heart that's a little pocket or something, and they actually took that and sutured it up or disconnected it, which is where your turbulence of your heart tends to build clots. So that also gives a further prevention of a possible stroke if AFib should ever return.
Do the doctors concur?
Yeah, what they did was tie off his left atrial appendage, which is, like he says, a little outpouching of the atrium where often clots can form. And there are both, you can tie it off surgically. There are little devices now that actually can be placed percutaneously to occlude it. So, yes, I mean, many people do not tolerate the medications in atrial fibrillation, though, you know, we generally don't recommend an invasive procedure because there are potential complications as the first choice. If they do tolerate medications, we go with that first.
Bob, what were your symptoms?
Well, I had a very high heart rate,
I mean, how could you
a
tell?
very low ejection rate.
No. How could you tell? I mean, I'm just saying, you're sitting in a chair, and how did you know that you had AFib?
I was tired at the time, much more fatigued. I mean, I've got, as you kind of already know this, Ray, I've got my energy back, and I'm still driving people nuts again.
Yes.
But I became very lethargic and very sleepy, and I was just blaming it on not getting enough rest and working too hard and too much stress. And so that was what I was just doing. And it wasn't until I went in for a cough, which also, because of the AFib, there is some congestion or congestiveness in the chest because my heart efficiency was way down due to the AFib. And I went in for the cough, and they took my pulse and kind of freaked out on it, gave me an EKG, said, my friend, you got AFib. It was actually a physician's assistant, and she put me over to a doctor, and the next thing I knew, I was down at the hospital, all hooked up to instruments, and then given all these medicines.
So no birthday cake.
And no birthday cake. And the doctors are saying about tolerating the medicine. Part of it is I just didn't like to take 5 different medicines with all of their side effects. And that's one reason, besides the fact that I needed to get this all under control, that I voluntarily chose and sought out the procedure and went to Houston, Texas, and got it.
I got you.
And to me, it was not that dangerous of a procedure compared to taking the blood thinners.
Noted, and that's something that Dr. Nurse Haddock and I were talking about earlier. Is there are going to be a lot of reasons why people may go on or off their medication, and some people it's just a question of tolerating it or dealing with that as part of their lifestyle. Their new lifestyle is I got to take a pill all the time. Hey, I got to run. I'll talk to you pretty soon.
Sure. Bye-bye.
All right, Bob Kelly, I appreciate you calling in. We were, while the break was playing, kind of chatting about some other things, and the keto diet came up. And let me think, there was no reaction from Carla. And Dr. Wasko raised an eyebrow, but Dr. Wiedermann here, you got some issues with the keto diet.
Well, I think most cardiologists have an issue with it. I'm sure Dr. Waska agrees with me.
Well, I mean, so
Yes.
we're
Makes
talking
no
about
sense.
lifestyle adjustments and maybe
Right.
some different kinds of diets for the patients that she's going to be putting into this cohort program. So is keto off the list?
Keto is off the list. You can't have a diet that's all fat and not expect to get heart disease.
Darn.
The other thing is, it's not a sustainable diet. You want a diet that you can stay on for your life, not a diet that's going to make you lose weight for the next month, and then you're going to go on to a normal diet and gain your weight again. But from a cardiac perspective, it's a nightmare. You're eating nothing but fat. That is going to raise your cholesterol. You're going to end up getting blockages in your arteries.
And now there is some value to having the carbs in your system, right? I mean, not enough just for people to go over that keto line, but I'd like to think that I've got a pretty healthy relationship with carbs. I don't eat as much rice as I used to. It's generally less than a fistful of rice when I go to the fiestas and the parties. I otherwise get my rice from the occasional cheeseburger and cheeseburger bun. It's my diet. I get to do whatever I want, and whatever's in beer, whatever carbs are showing up in beer, and I like to think that keeps me, with a decent level of carbs, and I will tolerate vegetables as need be.
Listen, again, it depends who you are, right? It depends whether you're a diabetic or not. If you're not, then moderation with carbs, but eating carbs is fine.
Yeah.
You want to comment on that, Dave?
Sure. I think in general, when patients ask me about what's a great diet, okay, I tell them that there is no one great diet. If there was, you'd walk into a bookstore and there'd be one book on the shelf.
Right.
Right? There's multiple dietary books out there. The important thing, as Joe said, is you have to eat in such a way that you can sustain it for life. Okay, so this is an absolute lifestyle modification thing for controlling weight. Okay, I also tell patients as a practical matter, I think Mama was right. Everything in moderation.
Yes.
Nothing in excess.
Right.
As long as you also do exercise, okay, 30 minutes a day, at least 5 days a week. That's what's recommended for all adults throughout the world.
Yeah.
So if you eat a fairly good diet, keep everything in moderation, and exercise, I think you're going to do yourself quite good for the future.
What kind of exercise? I mean, I'm big on cardio. I know people that do CrossFits and things like that. Is there a certain heart rate that I should be looking at?
Well, what you want to focus in on is 30 minutes of continuous aerobic exercise.
Right.
Okay. I usually tell my patients weight training is not good for the heart. It can gradually elevate the blood pressure, cause the heart to thicken. You can go into heart failure after that. So aerobic exercise.
Swimming,
now, what's aerobic exercise?
walking.
A brisk walk, right, a brisk walk. I mean, you can't go to Payless or Home Depot for 30 minutes and say, oh, I got my walk in today. No,
Right.
no. It's got to be a brisk, dedicated walk.
Uh-huh.
If you have access to machines, treadmill, stationary bike, elliptical, stair stepper, take up tennis, jump rope. We have a beach here, swim in the beach.
Swimming?
You have access to a pool, swim in a pool. But it's recommended at least 30 to 60 minutes per day is actually what the recommendation says.
Yeah. Well, as I say, is there a target heart rate that I should be shooting for? As I ran a half marathon over the weekend, and I think I was up around 170 for the majority of the time that I was running, and it dips down into the 140s and 150s. But it felt like it was a real comfortable range that I was running in. Is that good for my heart? Is there a number that is too high when I look at my my Strava and my Connect later in the day?
Yes, I mean typically, we do the little formula 220 minus your age and take a certain percentage of that. Usually what I do is I'll tell patients if you get 70%, I think that's reasonable. Yeah. Okay. During a stress test, we go 85%. Well, certainly we wouldn't want you to do that. There is a level where the harder you work, you don't get any more benefit. I mean, you've reached a certain level of benefit, and it doesn't matter if you push yourself harder. It's not really going to improve your aerobic capacity. It may actually be harmful, okay? So typically, I do 220 minus the age. Do about 70% of that number, and that would be your target heart rate.
I'm going to run that by my coach who's listening to the program right now, 9:52 in the morning. And I've got one more question for you, but my producer says I got to take a break, and I do everything that Mike tells me to do after I smirk. So I'll be right back.
At Chili's, our burgers stack up with anyone's. Handcrafted to order, smashed to lock in flavor on a toasted brioche bun. Our burgers are all kinds of perfect. Choose from the Chili's Chili, the Mushroom Swiss, the Ultimate Bacon, or you know what? We dare you to take on the Boss Burger. Loaded with smoked brisket, rib meat, jalapeno cheddar sausage, and bacon. We may have really out-burgered ourselves. Our burgers are more than a handful, served with garlic, dill, pickles, and fries. So hurry in today and enjoy our juicy, melty, yummy, handcrafted creations. Perfection between two buns. Chili's. More life happens here.
Helen Keller once said, blindness separates us from things, but deafness separates us from people. At Ross Hearing Aids, it's their mission to keep you connected to the moments and the people that matter most in your life. Hearing aid technology has never been better, so schedule your complimentary hearing consultation today. Call Ross Hearing Aids, 637-HEAR, 637-4327. You should hear what you're missing.
I love you, Daddy.
How's your hearing?
Okay, one last question on the heart rate. In your opinions, is there such a thing as a fat burning zone in terms of a heart rate? Something that I could get to, and it will after I've eliminated whatever sugars are in my system, start eating the fat around my belly.
I would say that probably around the 70% level.
It's actually someplace where I'm
reasonable thing because you want to maximize your fat burning and your caloric expenditure without harming the heart, by pushing it too hard. So I think you have to find that happy medium, and that's why I think if you get 70% of the maximum predicted heart rate, I think you'll achieve both.
All right, I'm going to do the calculations and see where I ended up yesterday.
And planks. If you really want to get rid of your abdominal planks. Sorry. I know they're terrible, but they work.
What's the easy one? What is the easy one here? What are we? They're always coming up with the hard stuff. Crestors. We'll talk about that the next time that you're in the studio. I do. There's Albert who is saying AFib and PSVT are issues I have that 25 years ago was diagnosed as a panic attack at the clinic. Heart rate over 220 BPM 7 times a day and often several times an hour. And that refers back to the conversation that we were having about AFib just a little bit ago. So I guess those are some of the symptoms. And at the time they looked at it and said, don't worry, you're just having a panic attack, stress in your life.
Right. Well, AFib and PSVT are two very different things. PSVT is something that these days we treat almost immediately with ablation because the success rates are above 95%.
Wow.
And they're due to an abnormal pathway of conduction in the heart, but a single pathway. So it's very easy to treat these days. And AFib, again, is a different issue.
So just kind of lock in on this. Now, there's a question that all three of you can answer, and I think it's an important question. There was a once upon a time I went to the Tamuning Senior Citizens Center and was taken through a course on what to do if somebody is having a heart attack, how to administer CPR to them. And like everything else from when I was a kid to where we are now, it's changed. So if I'm in a room somewhere, and this will happen to me one of these days, emceeing big events and stuff like that, somebody is going to have a heart attack. What do I do?
So I know back in the day it was always like the ABCs, right? Airway, breathing, compressions. But now they've actually changed it where now you as a bystander can just do hands-only CPR. And the Red Cross has great trainings for anyone out there that I think are free where you want to get hands on the chest and start compressions early on. And then, of course, if the facilities have the AEDs, those automatic defibrillators, to get that on the chest quickly.
Boy, and that's we still need to get more of those out in shopping centers and big hotels.
But you would be really surprised at the different places that actually carry them now. I mean, you can pass by them 50 times and not notice one on the wall. But lately, my children have been pointing them out, after they...
Oh, how cool.
Yeah, because they kind of got to watch my training videos when it's at home on the computer with me.
But there's that spookiness of doing that. I mean, I'd be okay with administering compressions, after I got the training to know exactly where to put the compressions and how many compressions to try to get in a minute. And I guess those would be the fundamental things, right? Is where and how often you want to be doing this. But if there was one of these defibrillators around, I'd kind of...
But what's great is right as you pop open as you pop open that cover, it walks you through everything. Turn it on. Right as you open that cover, it says turn the device on, place the pads here, and there's great pictures. Stand back, don't touch the patient. I mean, it walks you through everything. So even if you're a lay person, you can figure it out.
Right, and the very first thing to do, even before you open the box that
call
says...
911.
Yes, call 911.
Please, people forget that a lot of times is... Call for help.
Exactly. That's the first thing that you got to do. Is the first thing they told you when they tell you when you get into these training programs is look at somebody directly in the eye and use your best commander voice and say call 911 right now, and make sure that somebody scampers off in that direction to get it done. What did we leave on the table here? We're just another minute or so before we get off the air. So I can say thank you very much, Dr. Wiedermann, Dr. Woska, Carla. It's always great seeing you, and even more when we get the chance to have the kids all playing around together. Did we leave anything on the table that's important? Charlie, we get to it all? We did. All right. So if you're interested in becoming a member of this heart failure management program, again, get a referral and then start looking around over at GRMC for Carla Haddock, and she'll let you know what's going on. Otherwise, Charlie Laron is available over there, and Cindy Hansen's online right now. So if you got other questions, they'll be online for a couple more minutes as well before the program's done. Thanks for coming by.
Our pleasure.
And
Thank you.
There's going to be grill marks. Me and you, grill marks, and a beer.
Okay.
Whatever.
Size to be determined.
Exactly. It's closing in on 10 o'clock in the morning, the radio station. We're KUSG got you, and that's the segment is called Your Healthcare Partners, and always originally scheduled to only go for about 20 minutes, but we have so much fun exploring other issues as well, and so we'll do this again in another 30 days or so. For Michael Knight, Kevin Kerrigan, and Blake Watson, this is Ray Gibson saying thanks for watching, thanks for listening. Catch you tomorrow right here on the Ray Gibson Show on 93.3 The Point.